Welcome to the Doctors Making a Difference podcast, where we help physicians to be empowered with the tools they need to be successful in medicine, in finance, and in life. Join us as we highlight doctors and other professionals around the world who are making a difference. Today, I'm so excited to welcome Mary Doherty. She is an anesthesiologist practicing in Ireland and also has done a lot of advocacy work regarding autism spectrum disorder. And I've been a fan of Mary on some of the social media channels for a while. Super excited to connect with Mary. I think you'll find this fascinating to hear about her work, and I'm excited to welcome Mary to our program. So, Mary, would you mind introducing yourself to our audience?
Thanks. Yeah, sure. Thanks for the invitation. So I'm Mary. I'm an anaesthetist, the equivalent of a attending anesthesiologist, I think, across the pond. I work in Ireland, and I'm a clinical associate professor at the University College Dublin at the School of Medicine. I also have affiliations with some universities in the UK. I'm a parent of two neurodivergent young people, and I was diagnosed as autistic myself about 12 years ago. I also have an ADHD diagnosis as well.
Yeah, so you've lived it from your family standpoint and personally, as you got that diagnosis more as an adult. How interesting. So
Mhm.
tell us a little bit. Just I want to hear your journey, Mary. How did you decide? How did you choose medicine? How did you choose anesthesiology? It's interesting you ended up in this space, and then also later on you had children with autism spectrum or neurodiverse type things, and so you ended up more in this space. But I want to hear the origins of how did you end up in this world?
I think I decided I wanted to be a doctor when I was about 4 or 5.
Oh, quite
Um,
young.
yeah. And it's really poignant how that happened because one of the big issues for autistic people in terms of healthcare, because that's my research background, I do a lot of work around healthcare for autistic people. One of the really big issues is pain, and both how we experience pain and how we describe pain, and how we're often not believed because we don't express pain in the way that, non-autistic people might. But as I remember back to being a child, I would have experienced very recurrent abdominal pain. I remember that so clearly. And I remember what it felt like. And it was always the same sort of pattern. It would have a certain type of pattern of pain over a couple of hours. And it happened with a devastating regularity. Um, but I wasn't believed. I was never believed, or very rarely believed. I had lots of investigations. I've been seen by doctors. And the overriding sense was that I wasn't believed. Um, and I remember thinking as a small child, when I grow up, I'm going to be a doctor, and I will always believe my patients when they say they're in pain.
Right.
Um, and now to be working in the area of autistic healthcare, and particularly when pain is such a key aspect, it's quite poignant. But that's how it started, and I very rarely wavered. I briefly wavered, and said no, I didn't want to do it. I wanted to do something else, but I went back to it. And again, the reason I chose anesthesia was for very autistic reasons, even though I had no idea that that I was autistic at the time. This was back in the mid 1990s, I think. And at the time, medical training was not as structured as it is now. And anesthesia was one of the specialties that had the most structured training, which appealed to me, and the most structured schedule, which appealed to me. I like the idea of dealing with patients sequentially, so one patient at a time in the operating theatre, rather than, 20, 30 patients all together on a ward. But the other thing was that I could wear scrubs rather than having to wear my own clothes.
That's a
I
good
really
point.
liked the idea of wearing scrubs because they were comfy. Yeah, now I know that's related to autistic sensory needs. No idea at the time. But looking back, it was quite interesting. There were the reasons, they were partly the reasons. Also, I loved the, procedural aspect of anesthesiology. I enjoyed that as well. I enjoyed the maths and the physics, and yeah, it was just great. One of the misconceptions about anesthesiology, and particularly autistic anesthesiologists, is that, oh, well, yeah, you choose that because you don't have to talk to the patients, they're
Oh,
asleep. That's not true at all. We really do need very high level communication skills. And again, it's one of the misconceptions about autistic doctors that we don't communicate well. It's not true at all. But they were the things that I loved about, anesthesia. So that's how I got into it.
Well, so just reflect back on that for a minute. Mary, why do you think that they didn't believe you regarding your pain when you were a child?
Oh, I think there was no clear physical signs. Um, And, autistic people, we tend to not express pain in the same way that non-autistic people do. So maybe I didn't look the same as other 4 or 5 year olds who would have had, significant pain. Um, I think there is a lot of unexplained physical illness in the autistic community. Autistic kids deal with a lot of gastrointestinal problems, and that's now recognized, as a very common co-occurring condition for autistic people, both kids and adults. And looking back, I don't know. Again, I don't know if it was that I wasn't actually believed, but that was certainly my perception. Maybe it was the fact that, the physicians looking after me recognized that this was, maybe who knows, maybe it was chronic constipation, maybe it was anxiety driven, maybe it was psychosomatic, who knows? Even as I look back, I don't know what was going on then from a physiological perspective, but I do know the pain was real,
Oh
and
yeah.
I do sense of, just losing trust in caregivers at that sense of not being believed. It was
Well,
really, it was really hard.
I think for everybody, because I mean, I'm a primary care doctor, so we see
Mhm.
people of all walks, and it's interesting because I think the world has become, well, I think doctors are a little bit better trained to realize that not all pain is going to present the same.
Mhm.
But classically speaking, if the person doesn't have a physical finding, it was
Mhm.
hard to believe they're in pain. And I think there was a thinking years ago that the person was making it up or that they had looking for secondary gain. But certainly as a 4 or 5, 6 year old child, most kids don't make things up. They either hurt or they don't. And maybe it is constipation pain. Maybe it's pain that's psychosomatic. We don't know, but the is pain is pain. The person feels it.
Yeah.
Doesn't mean you need to put them on narcotics, but you should address why
Exactly.
the person is having the pain for sure.
Yeah. And even validate it, even if you can't find a physical cause, just validating. And that is actually one of the findings that came through in some of the research that I did when I was looking at barriers to healthcare for autistic people. The sense of, just how important it was to be believed by doctors. Even if there was nothing that could be done or if there was, no specific treatment or no specific physical cause that could be found, being believed was incredibly important. And that's across the board. That's not just autistic people, but I think it's probably more so for autistic people because we're less likely, I think, to be believed.
Yeah, and maybe that's a good message for me and for anybody listening to just validate and say, okay, I recognize you have pain. I can't find the reason for it. I don't have a specific physical cause that we can point to and say you have pain because you have this thing wrong inside your body specifically. But to say, but pain doesn't always have to have an explanation. If you hurt, you hurt. Now, how we treat that doesn't, sometimes people come in seeking opiates or something that is maybe inappropriate, but there's so many ways of treating pain, and we don't want to invalidate the person's pain while we're doing that. So it's interesting you experienced that as a child, and now you're a professional who deals with pain and with anesthesia, not just to put people to sleep for surgery, but also to deal with the various pain conditions that people deal with. Another one, Mary, just to reflect with, you mentioned the idea that in anesthesia, you do have to do a tremendous amount of communication. In fact, you have to build rapport very quickly because you don't have the luxury of 10 appointments to build a relationship of trust. Often you're encountering that person for the very first time and then doing something where you're taking them to kind of the edge of death,
Yeah.
where you go to anesthesia prior to a large surgery and the person has to trust. And I think that requires a high level of communication. I
It
reflect on
really does.
in my own life, when have had anesthesia, I've I feel like I'm giving my full trust. I'm putting my very life in the person's hands, and so I'm confident you've had to have a high level of communication for many
Absolutely.
years.
And particularly when people, present for emergency surgery, or the other aspect of our professional life would be, intensive care medicine. When people are critically ill and we have to, admit them to the intensive care unit, because often certainly in Ireland, anesthesiologists, would work in intensive care as well. Um, And just that sense of having to develop that really deep rapport with the patient where they are willing, and confident to put their lives in our hands. That really
Mhm.
does require, a high level of empathy and, high level communication skills. Yeah, for sure. And lots of us are really, really good at it, contrary to the stereotypes. Mm.
Oh, absolutely. Well, so you chose anesthesia, and unbeknownst to you, you had an autism spectrum diagnosis, but you just didn't have the diagnosis. You just had the disorder.
Well, can I just stop you there and say
Yeah.
I don't really conceptualize autism as a disorder. I know technically it's in the
No,
diagnostic
I
manual.
think you're right. We should. I think I'm glad you
We need
corrected me
to
on
move away
that.
from that. We need
I'm
to move away from that. Yeah. Mm.
I'm glad you corrected me on that because I think that we should think about it as just it's a spectrum, and
Difference.
so yeah,
Yeah.
when you talk and lecture regarding autism, yeah, how do you recommend people put that in that framework? Because that's very important because we want to we want to talk about it for what it is, because people have challenges associated with sometimes. But at the same time, if we put everybody in the column of disorder or disease, sometimes we disable people just by our nomenclature. So yeah, help me figure out how do you talk to people about that in a way that's constructive and building.
Yeah, we need to move away from that traditional core deficit framing.
Uh-huh.
That has been so common in medicine, where autism is seen as this disorder, this disease, this thing that needs to be cured. Not at all. Um, it's a different way of experiencing the world. It is absolutely a disability. But we have to move from that core deficit framing to a neurodiversity affirmative approach and just recognize the benefit of all sorts of minds, and the world needs all kinds of minds. Medicine needs all kinds of minds. And just recognizing that we are different, not less, not disordered, not broken. Um, but undoubtedly there are challenges, and I have no difficulty in conceptualizing autism as a disability. It is 100% a disability for most autistic people. Not all, certainly not all autistic people would identify as disabled. I do. I have no difficulty, acknowledging that there are challenges in my life, particularly in a world that is not geared towards the needs of autistic people. There are places I cannot go. There are things that I cannot do because I am autistic. And it is undoubtedly a disability. But there's no, there's no conflict between the idea of seeing autism as a disability and the neurodiversity affirmative paradigm. The neurodiversity paradigm really is it's the way to optimize outcome for autistic people, particularly autistic kids. Because the thing is, autistic kids really need the opportunity to grow up confidently autistic. The idea of trying to hide our autistic traits, masking, as if being neurotypical or non-autistic is the bar to which we're supposed to aspire. That's so damaging. It's so damaging to autistic people. Um, and there's growing evidence to show that. We found that amongst our own members. So we've done a survey of our own members in Autistic Doctors International, which showed that the majority of our members would view autism as a difference, an identity, and disability. But there's a minority, a group, who would see autism as disorder. Um, that group had worse outcomes. That group had an association with prior suicide attempts.
Hmm.
And if you think about it, it makes sense. If you grow up, with the message that you're somehow broken and defective and disordered and need to be fixed, it's no wonder by the time, you get to be an adolescent or an adult that your mental health is shot and that, you're more likely to not want to be on this planet. We have to change that. And that I think is probably what drives so much of the work that I do, just trying to change that paradigm so that people have the chance to become get confidently autistic, to own it, to just embrace who we are, our authentic selves. Because gosh, there's nothing more wonderful than, living an authentic life.
So I think that's one. I think that's a good phrase to kind of take from that discussion is confidently autistic.
Yeah.
And and there are certain things, many things that we treat in medicine where we kind of have the disease paradigm. Like if we fix your disease, then you go back to normal physiology, which is great.
Yeah, but like, yeah, being gay was in the DSM 50 years ago.
Right.
We had the same sort of framing around being, about being queer. Um, you know, and look at the changes that's happened over the last couple of decades. We need to take that same pathway. Now, it's not a perfect analogy, but there are some parts of the analogy that's really, really helpful, and particularly in terms of, how we frame the concept.
So one way I've just kind of thinking about this with this confidently autistic, um, you might think that the autism spectrum is something that's likely to, or neurodivergence is something that's likely to be with the person for all of their life.
Oh yeah, of course.
It's not something you give a medicine or do something and the person no longer has the disability.
Oh,
And like you said, there are some disabilities associated with that, and we have to kind of uh, adapt to or manage or enable people to be the very best versions of themselves. But it's just interesting because in medical school, I think most things that I was taught, probably most people are taught, is the idea of normal physiology, anatomy, function. There's kind of this normal bell curve, if you will, where people exist, and then we try to do everything to bring everybody back into this bell curve. But in multiple disorders or disabilities or whatever the correct terminology is, we don't necessarily have that opportunity. So with neurodivergence, for example, most folks are going to deal with that in some way for all their lives. And so, I guess what's the most empowering, confidence aspiring way for physicians to interact with both peers and with patients in that, when we're talking about this.
I think to recognize that neurodiversity is to be expected. Like our society is neurodiverse. Um, and it's to move away from that sort of neuronormative expectation, as you say, that, everybody is supposed to fit into this, middle group, of normativity, um, and just valuing difference.
Hmm.
Like we have so many examples going back in history of, scientists and physicians, who clearly saw things differently, and who had huge amounts of innovation to bring to the world. There's so many inventions that we wouldn't have apart from, autistic people thinking differently. And it's just to recognize that really, and also to recognize that diversity, I mean, the concept of neurodiversity grew out of the concept of biodiversity. And we all recognize that biodiversity is beneficial for a healthy planet, and recognizing that neurodiversity is beneficial for humanity is really the place to start. It's to recognize the benefit of difference, rather than seeing that, as a problem. And then it's interacting with people that in ways that encourage that authenticity. I see it in my own kids. I have two kids, and they're both happy for me to chat about their stories as well as my own. And indeed, going back to how I recognized that I was autistic was after my younger child, my son, was identified as autistic. And I was thinking back because at the time, none of the things that were flagged as, potentially autistic seemed in any way strange to me. It's like, aren't all kids like that? I was like that. And then realizing that actually, well, no, the majority aren't. Um, but then at the time, my older girl, and the kids are 14 years apart. My older girl is neurodivergent, but we didn't know that when she was little. So she grew up in that sort of pathology paradigm where it was, and when she ran into difficulties, it was what's wrong, how can we fix it? That sort of mentality. And we had no idea what neurodivergence looked like in girls, and she struggled very significantly with her mental health. So by the time my son was being assessed for autism, I'm so grateful to his preschool teacher who was the one that spotted it. Um, by that time, my daughter was experiencing really significant mental health problems, and I mean really significant. Um, and looking back, if we had known about the neurodiversity paradigm then, if we had known that girls could be neurodivergent and known what that meant, I think she would have had a very different upbringing, and a very different outcome. She's doing great now. She really is. But, we both look quite poignantly at my son, who has grown up in that neurodiversity paradigm. He's confidently autistic, and it's wonderful to see. He's got significant challenges. He's in special education. There are certain things that he can't do. But at the same time, he's confident in his identity, and I have no fears for his mental health, and I think that's the important thing. I think that is because the mental health outcomes for autistic people are just so awful. Like the suicide rate for autistic people, 7 times the general population rate. 9 times for those without an intellectual disability. And when you look at women without an intellectual disability, autistic women without an intellectual disability, that's up to 13 times the
Mm.
suicide rate for the general population. And I have no doubt that so much of that is due to that sort of disorder framing, that deficit framing. Which is actually a theme that's coming out in some of the research that I'm doing currently, which is looking at the experiences of autistic psychiatrists. And
Wherein the psychiatrists themselves have autism. Okay,
yeah, they're
interesting.
autistic. Yeah, for sure. So just to get a bit of background in terms of Autistic Doctors International, so I started that group back in 2019. And there was 10 of less than 10 of us when we started. We now have 1,200
Oh
members
wow.
spread right across the globe in all continents, including Antarctica, which is quite cool.
Oh, how interesting.
Mhm. Yeah, so many of our members have really niche areas of interest, which is maybe not surprising. But interestingly, the specialty breakdown is not what people tend to expect. People tend to think, oh, we're all pathologists or microbiologists or stuck away in labs away from people and patients. It's not the case at all. The biggest group are general practitioners or primary care physicians, family medicine. And the second biggest group are psychiatrists. And of course, then when you consider the relative numbers of general practitioners, family physicians, and psychiatrists, then the question is, well, are the psychiatrists the most overrepresented group in ADI? And they do seem to be, for sure. Um, so yeah, so I've recently done a PhD, just pulled all my research together into a PhD over the last couple of years.
Congratulations.
Thank you, thank you. I mean, if I'd known I was autistic years ago, of course I'd have done that years ago. I'd have gone down an academic track, and it's sad for me that I haven't, looking back when I think of what might have been. But anyway, it's never too late. We are where we are. But one of the projects in the PhD is looking at the experiences of autistic psychiatrists. Yeah. And there's a couple of interesting findings from that. First of all, that they exist at all,
Right.
because sometimes people would think that that's not possible. Um, but look, I mean, of course it is. Even when you look back to the development of the diagnostic manuals, there's evidence. So Steve Silberman Steve unfortunately died recently, but he was a wonderful advocate for the autistic community, and he wrote a fantastic book called Neurotribes, which documented the history of autistic people and the autistic movement. And he one of the chapters is called Pandora's Box, and he talked about the development of the DSM, the diagnostic manuals that we're all familiar with as the Bible of psychiatry. And what he said was the DSM-3 was the product of a mind that exhibited many classic qualities of autistic intelligence. So right back at the early days of psychiatry, we have to recognize the value of autistic thinking, because we see things differently to non-autistic people. Anyway, I went off on a tangent there. But the thing about the autistic psychiatrists was that what they said was, so the project was looking at their journey, how they came to recognize themselves. Um, for some of them, it was through lectures, for example, teaching, although that was rare enough. For others, it was like myself, after their kids were recognized. Some were recognized by their patients. It's like, hey, you're one of
Oh,
us,
how
aren't you?
interesting. Yeah, your patient like, I think you might have autism.
Exactly. Yeah, exactly. Yeah. You're one of us, aren't you? Yeah. But then what they said was, once they realized that they were autistic themselves, they recognized that loads of their colleagues were, particularly those working in the area of autism or, in neurodevelopmental psychiatry. Um, and again, that's not surprising if they find that if they find, it easy to develop rapport with autistic patients, well then, that might be because they communicate, on the same wavelength. But what they also said was that before they recognized, and this is a really important point, I think, it's really interesting, before they recognized that they were themselves autistic, they missed the diagnosis with autistic patients. Because autistic patients would come in and, recount a fairly standard list of autistic features and experiences, and the assessor would go, "Sure, that's like me. I'm like that. Everyone's,
Hmm.
that's all done,
Well, kind of like what you said with your kids. Aren't all children like
Exactly,
this?
exactly. Yeah, exactly. Yeah, and they just missed it. And the thing is, there are loads of people now, there are loads of psychiatrists now who don't realize yet that they are autistic. And a lot of that is because what we've been taught is that core deficit model, the diagnostic criteria, they're all a list of how you have failed to be neurotypical. There's so much more to being autistic. And the diagnostic criteria don't leave any room for thriving as an autistic person, which of course we can. So it's hard for successful physicians, particularly I think successful psychiatrists, to see themselves within that. But that's why the benefit of moving to a neurodiversity model is just so beneficial. But yeah, there's loads of psychiatrists who won't yet realize that they're autistic. Or or some do, and it's quite painful to watch actually, because some do know, but because autism is just such a stigmatized label, they just can't be open about their identity. And then the next part of my project is looking at the reasons why people, why they can't disclose, and it's quite sad, but the overarching theme as to why autistic psychiatrists don't disclose, is shame.
Hmm.
And that has led me to look at the idea of autistic shame much more widely, and just recognize that it's not something we talk about a lot at all, really. We talk about stigma in the autistic community and, in autism research, we talk about stigma an awful lot, but we don't talk about how that stigma is embodied on an individual level, and that's shame.
Hmm.
And of course, shame is just such a painful emotion. It's so hard to deal with. So this is a really tough period of my sort of research career at the moment, just having to deal with that. But I'm going to be presenting this work at the American Psychiatric Association annual meeting next week, the week after next. And I'm hoping that, people will just recognize the potentially transformative benefit really of just embracing this, rather than running away from it. I'm finding that it is resonating so deeply on such a visceral level with so many people. Like I presented it at INSAR last week, which is the International Society for Autism Research. The meeting was in Seattle, which is why I'm so jet lagged and I
It's like
forgot
that's a lot of jet lag.
for sure, especially heading back to Los Angeles for the APA next week. But there was one researcher who looked at my work, and she stood there and she just looked at it for a few minutes, and I could see that this was really impacting her emotionally. And she turned to me and she said, "I feel this with my whole soul."
Hmm.
Wow, to be able to sort of put the pieces together in such a way that people can see what has been done to them, what has been done to us, because this is not our shame. There's nothing shameful about being autistic, but this has been imposed on us because of the messages that we receive about what it means to be autistic. And I just want to change that. I want people to, because once you recognize what we're dealing with, we can all talk about stigma, but there's nothing really that we can do on an individual level about societal stigma. Not really, but we can address our own shame. And the way to do that is self-compassion and becoming shame competent. So I'm actually going to talk about this at a conference in the UK in June, which is Shame and Medicine. So that's in person in Exeter, and it's online as well. So for anybody with a particular interest in that, just look up the Shame and Medicine project. It is a wonderful project. That's been running for the last 5 years, just looking at the impact of shame in medicine, which isn't something we talk about. And like, even in terms of the way medical education is, shame is used as an educational tool all the time. We don't call it out, we don't recognize it. And this project looks at the impact of shame for patients as well. And it's been termed an effective determinant of health, where it's a barrier to healthcare for people, for patients in general. So I'm just really at the start of investigating all of that, and but it's fascinating.
I love your passion. I can tell this means a lot to you, which is so cool.
Hmm.
Um,
It really does.
One of the things that I reflect with my patients sometimes is we often use those feelings of shame or guilt inappropriately. And so the thing I always tell patients is, guilt is for sin. If you rob the bank or
Yeah.
if you lie to somebody, that's what that's for, is to be like, I need to change. I need to self-correct my behavior. It shouldn't be something that we impose on others. Like you should be shamed and guilty. It's really supposed to be an internal correction to say, okay, I've done something where I wronged another person, and that's something I need to correct in my life. But when we impose it on somebody else, that force rarely produces good change, and it rarely
Mm.
produces long-lasting change. And one way I think about it is when people come in, and for example, someone needs to quit smoking. It's not a very empowering message when you shame them, but it is empowering when you say, well, let's talk about why you would want to quit and what's the benefit, what are the science, what are the things that might help you, and then get yourself to the place where you want that, not because of guilt or shame, but because of wanting to change it. And
I
I
can see
think,
the benefit. Mm.
yeah, I think what you're talking about, where we say guilt and shame don't really have a place in medicine. It's our job to help people go away
Yeah.
from societal shame that they might feel, that even if they're not verbally being told that, if somehow that's being imposed upon them, it's really not a very helpful thing. And like I said, I think that's more of an internal thing. That when we feel that specifically because we've done something wrong, we've hurt another person, we've taken something that doesn't belong to us. That's something that helps us correct ourselves as people and kind of provides part of our conscience or our self guidance. But when we have a society doing it to us, we feel all, well, I'm bad, I'm terrible, and then of course
Yeah.
people are more likely to hurt themselves or not aspire to what they could have been. So I love your work. That's so cool.
Yeah. No, so much of it is inspired by the Shame and Medicine Project, and that's Professor Luna Dolezal at Exeter. I only like discovered that work quite recently, and it's incredible because even recognizing the difference between guilt and shame. Guilt is about, as you say, something we've done. Shame is about who we are,
Hmm.
our core identity. So much more powerful, so much more destructive. And even looking at the sort of connections between shame and substance abuse, for example, shame and anger, shame and violence. Um, Not stuff that I ever was ever taught about or learned about through my training. So it's really fascinating. And so much of the public health messaging is shame based. It's deliberately used to try and change behavior. But yeah, I think there's something very specific about autistic shame that needs so much more research, because I think as autistic people, we're um, sort of, we can be very forthright and blunt to the point of being blunt but willing to take things on and not beat around the bush, shall we say? Not sort of use euphemisms. We'll really grasp things, and I think that's a huge opportunity for autistic people most of us we have been raised in chronic shame, and the thing then is that's really interesting is shame anxiety. So while we might not even recognize shame, so much of how we live our lives is based around avoidance of shame. So much substance misuse and addiction and chronic ill health, mental health problems, mental illness. It's all based in shame anxiety. So definitely look at the work of Professor Luna Dolezal and the Shame and Medicine
Hmm.
Project and this fabulous podcast that they've done. Um, so yeah, I mean, I'm just blown away by the enormity of it. Like it's been called the elephant in the room, and I think it really is in medicine. There's a lovely editorial, I think in the BMJ or the Lancet from several years ago about shame as the elephant in the room in medicine, and it absolutely is. So even though sometimes people don't are not receptive to the work that I'm doing. This has not been universally welcomed, I can certainly say, but I still have to persist because I know how important it is for people who are ready to embrace it.
Oh yeah. One thing I was curious about, I remember I attended medical school 2004 to 2008, and the word autism spectrum disorder was just starting to be used a little bit then. But when people had a diagnosis of autism, it was very much taught as the disease model. And then neurodiversity, I feel like, is a term that's come on even later than that. When you think back,
Yeah.
when would you say that people kind of stopped seeing it just specifically in the disease model and started talking about autism spectrum rather than just categorizing people as severe autism or Asperger's, or and when would you say that we've kind of started talking a little bit more about
Yeah. That was
neurodiversity?
in terms of talking about the autism spectrum, that was certainly the DSM-4, that which would have been back in around 1994,
Yeah.
and a lot of that was the work of Lorna Wing in the UK. Um, and but even then, I mean, even now, there's a lot of people who still think about it in that, sort of disorder, disease, deficit model. But I think it's interesting that I think this goes back to the birth of the internet, really,
Hmm.
where autistic people, autistic self-advocates, first started to get together, I think back in the late 90s, maybe the 1980s. But certainly the first gathering of autistic self-advocates happened in the mid to late 1990s, as far as I remember. And Jim Sinclair wrote an amazing, it was a transcript of a speech, I think. Don't mourn for us. That was a seminal moment. And
Hmm.
it was the idea of, autistic people being being authentically autistic rather than, this idea of the autistic child being, this trapped inside a shell, or so, parents mourning for the child that they had lost or they didn't have, or that was the first public resistance to that idea, and that has just grown. So the idea of neurodiversity, even the word, the concept, that grew out of the autistic self-advocacy movement, which followed on from the disability rights movements, civil rights movements from a couple of decades prior. And basically, it was just autistic people getting together and realizing, hey, we have a right to be on this planet. We exist in a way that is different to the majority. But that doesn't mean that we're broken, disordered, diseased, defective, and that applies right across the entire spectrum. So there is this idea that people, autistic people who can talk, are very different from autistic people who can't, for example. And while there are some very obvious differences, there's also a lot that we share, and part of a lot of the work that I do is about healthcare for all autistic people. And it's really helpful, I think, to go back and think about, what it is that we all share. So we've actually developed a framework that's quite helpful for healthcare providers. So it was developed with myself and two colleagues from Autistic Doctors International, and it's called the Autistic SPACE framework. And that goes back to the very earliest days of autistic self-advocacy, where Jim Sinclair and other advocates described being together as autistic space, being in autistic space. And we've actually used that as an acronym to pull together all of the aspects of being autistic that healthcare providers need to know about. Because we haven't had the training, commonly people want to help, but have no idea even where to start. What does it mean to be autistic? What might my autistic patients need? And that's why we developed the SPACE framework. It's a descriptive acronym because mostly what we need is a bit of extra space. But the acronym itself stands for sensory needs, predictability, acceptance, communication, and empathy. And then we talk about three other domains: physical space, processing space, and emotional space. That we published that in the British Journal of Hospital Medicine. It's open access. Anybody can use it. Please do. If you want to find ways to support your autistic patients, there's some really good suggestions. In that article, and it's short. That's the thing, because we'd written loads of really big stuff. Big long articles, book chapters. And we realized that our colleagues don't have time, like non-specialists don't have the time for that. So that's why we wanted to make something that was simple, memorable, and yet comprehensive. So we've subsequently written it up for anesthesia as well. And we've written it up for social care. We currently have a paper in revisions at the moment where we've written it for education, because what we find is that it's really versatile. It describes the core needs of all autistic people in all sorts of settings. I also use it in my training with in terms of supporting autistic colleagues. Because what I find, and this has been really interesting, is that an awful lot of physicians, while they have an interest in looking after autistic patients, When I started talking about autistic colleagues and autistic trainees, autistic residents, that's when the interest just skyrocketed.
Hmm.
Because, and I was wondering, I was thinking about why. I was thinking maybe it's because somehow that's about us in a way that looking after patients isn't. Maybe, I don't know. Certainly people who have autistic kids, autistic grandchildren, autistic nieces and nephews. And then they realize that their residents have, maybe similar needs. That's when people get really, really interested. So what I try and do now is I use the autistic space framework, whether I'm talking about patients or colleagues, and tie them both together in a way, because we all just need to understand um, what it means to be autistic, what are the kind of differences, what are the sort of things that we need. And one of the very early pieces of work that I did was with the Royal College of Psychiatrists in the UK. And we did a report on adult autism. And one of the first recommendations was that all physicians, and well, all psychiatrists, but it's relevant to all physicians, should become familiar with the autistic world, and still that really encompasses so much of of what I do. But we need to go beyond that. Now I'm saying all physicians need to become not just autism aware, but autism competent.
Hmm.
I think we have a way to go with that, yeah. But we're getting there because the level of interest, it's just phenomenal. And what's wonderful to see is even in mainstream healthcare, we're seeing that shift towards a neurodiversity model and that shift away from disorder model, which I think is hugely positive. We're seeing it particularly in child and adolescent psychiatry, and we're seeing it in pediatrics as well, particularly. And the thing about it is that journey, making that switch from that traditional core deficit framing to a neurodiversity model, um, that's a one-way journey. When people get it, they don't ever go back because they see the benefit for their patients, for themselves, for their colleagues, so people don't ever go back. But again, it can be hard to make that journey. And again, I'm seeing links with shame as well, because if you've spent your career um, in that sort of core deficit model and you've with autism as disorder and you've operated on that basis, then making that switch to a neurodiversity model can be tough because it means acknowledging that some of your past work may have done harm, and that's particularly relevant for researchers, I think, in the field. And also recognizing that, for example, ABA is really harmful for autistic kids, recognizing the damage that can potentially happen. And moving from that sort of behaviorist approach to a more neurodiversity affirmative approach, it's probably the most important thing that physicians can do. But it can be tough. It is
Well,
hard.
yeah, and I think about, like I said, primary care physician, and it's interesting to think because usually when people come in, they aren't looking for high-minded. Um, I mean, it's good to kind of put it in that framework. But a lot of people are coming in to me with a problem, like, oh, this child is having a problem coping with this situation, or
Yeah.
this adult's having troubles, and so it's always good to put it in the framework. I like the idea of the empowering neurodiverse, like you have strength and power because of what you are and what you do, and but even so, you do have to manage the some of the disabilities associated with it, and sometimes that is just making space for the person to adapt. Sometimes there are medications and things to help with some of the overwhelming emotions associated with it. And sometimes there's counseling techniques that we found to be really effective for some of the kids, so that or adolescents or even adults who say like I need to be able to talk this out so I can work it out. So, but I do love that idea of the autistic space framework. Where would you tell patients or doctors to go look it up? I know you mentioned a
Well,
couple of journals. Where's the easiest place to get it?
the British Journal of Hospital Medicine, or the probably the best thing to do is have a look at the Autistic Doctors International website, particularly if you're interested in the work, because all of our work would be linked. So we have a link tree with all of our papers, and the paper, the space framework is there. But if you just Google my name, Mary Doherty, Autistic Space Framework, you'll find it very easily, and it's open access. It has a license such that anyone can use it. You can adapt it. You can do it. You can do whatever, however it works for your practice. Because even in terms of the sensory needs, um, people don't realize that we experience the world very differently, and we don't accommodate to sensory input, for example. Like, so, if you're living beside an airport, after a while you won't even hear the planes. That doesn't happen for autistic people. There's good evidence to show that we don't habituate in the same way. If a kid is struggling to wear a school uniform, then they need to not be, forced to wear it. You need to find an alternative
Hmm.
that is tolerable. These sort of things. Sleep is a really big, it's huge. It's really important. But the thing is, autistic kids often don't need as much sleep. Like, I remember when my son was little, he needed less sleep than I did.
That's
And
hard when they're little.
it was really hard. And I was working full time, and it was really, really hard. But we had to find ways to manage that as a family. Melatonin has been phenomenally helpful, in our family. And the other thing was teaching him how to use the TV remote, you know.
The
So the family
electronic
room.
babysitter.
Absolutely. If he got up at 4 o'clock in the morning, that was fine. There was things that he could do, including watch the TV, but he couldn't, there was certain, certain rooms that he couldn't go into. But he could go and watch the TV. And eventually he learned to just do that and not wake me, and that was great. I'm not saying that will work for everybody. But it's about finding ways that work, and finding ways that are safe and effective, and not trying to fit kids into this neurotypical box, you know?
No, and you have
Um,
to adapt. I know my mother, I liked to get up early when I was a kid. My mother asked my first grade teacher for extra homework, and because I
yeah,
would get up at 4:30 and I would just sit and do homework, which was kind of
right.
silly, but it worked for me. And and then later years, I wished I could wake up. I wish I could have that sleep back. But when I was a little kid, I was up and ready to go, and my mom and dad needed the sleep, and you have to
Yeah,
adapt.
exactly.
You have to make those
Absolutely. Yeah.
adaptations.
Yeah, and just knowing what a kid's sensory profile is. Are they sensory avoidant? Are they sensory seeking? If they're sensory seeking and they're climbing on everything, they need ways to sort of, meet those needs. We used to go climbing as, my son was very young, because he'd be up on everything otherwise. But the last thing I wanted was to be, in constant conflict with him, constantly saying, "Get down, you can't climb." I let him climb. I mean, hoping that he wouldn't fall off. And in fairness, he didn't, but again, as a doctor, knowing that, like, I mean, even if bones are broken, they heal, like,
Right.
it's not big a deal. So he would be encouraged to climb up the outside of the banisters in the house
Nice.
in a way that was safe. But I also took him to the climbing gym, so he learned about safety, and he learned about that very, very, very young. So it was about, so he had the climbing frame in the garden, and the, climbing frame and the trampoline in the garden. And, he was always encouraged. We have a mini trampoline in the living room. We've always had one of those. Really helpful. Just allowing him to stim as he needed to, to not saying, "Oh, stop making noise," or, the only time actually we had to modify some of his stimming was in the climbing gym, because he doesn't do it anymore, but he used to have a habit of clapping very, very loudly. And he would launch himself along the hallway in the house, and he would kind of body slam up against the wall. Oh, because he needed that sensory input. That's all very well when you're at home, but that's quite difficult in a climbing gym when people
Yes.
are, free climbing, and, it became a little bit dangerous. And he was at risk of being excluded from the gym because of his sort of spontaneous clapping. Um, and that was the first time I had to think about, okay, so how do we modify this, and what do we do? So what I did was we talked to him about it, and he didn't really have the capacity at the time to moderate that behavior. But he was motivated to do so. So what we ended up doing was finding a different thing with the help of an occupational therapist. And certainly occupational therapy is the most useful. An autism aware occupational therapist is absolutely the most useful intervention for
Hmm.
autistic kids. And what we did was we found a way of modifying what he did with his hands, in such a way that it didn't make noise, but it did give him the sensory input that he needed. But just by bashing together the thenar eminences, and that's what he did, and it worked. But it was so different to, the traditional kind of ABA behaviorist approach. And it meant that he could continue his love of climbing, in a way that didn't bother other people. And again, it's just a different mindset. It's seeing it from a different perspective. How can we, and it's the same with kids who don't speak, there's so much focus on, oral kind of production of speech, whereas actually, no, the kids just need to learn to communicate, whether that's by spelling, whether that's by typing, whether that's by, picture exchange, whatever they need. The goal is communication. And again, it's just a different mindset. And mostly, I think what's really important is that autistic kids find community, find other autistic kids. So I mean, parents sometimes don't want their kids mixing with other autistic kids. They want them to mix with neurotypical kids because they want them to, act in a neurotypical that's just so damaging. What we need community. We need to know we're not the only ones. And we need to develop authentic friendships and relationships. And that's so important.
Well, and you hope for a day where a group of kids are playing and some are neuroatypical, so some are neurotypical, and it's just free play. We're not trying to say that you must act this way. You have to do things that, I mean, I've got four kids. Sometimes they're naughty. You have to do things that are not going to damage other people or going to like break the house down. But at the same time, you want them to be able to express themselves in a pretty free form. And, you want to, as parents, somebody told me a study recently that we have since the over the last 10 or 15 years, the number of long bone injuries related to trampoline jumping and stuff like that has gone way down because so many people, we're protecting and protecting and protecting.
Yeah.
But for autism spectrum, especially, it's good to let kids experience. You don't want to have someone get a C-spine injury or something that would
Oh,
cause anything
exactly. Yeah.
dangerous, but at the same time, it's probably okay to let them jump on the trampoline and jump and do a little bit. My kids are always feel bad that I always tell them not to break their bones on the trampoline, but
Yeah.
it's also hard.
But safe use. The other thing about autistic kids generally is they tend to be very rule bound. You
Hmm.
know, um, that's a very common autistic feature. So if you make the rules explicit, and that's the other thing about communication, so much of our communication is unspoken. There's hints and, that kind of hidden curriculum in medicine is a really big issue for autistic trainees. But if you make the rules very explicit, and the autistic kids understand the reason for the rule, they don't break the rules. You
Hmm.
know, so yeah, no, I think definitely having that physical outlet is really important. And also at the same time meeting their sensory needs. So naked trampolining is something that I would be quite quite in favor of for autistic kids if that's what they need.
Right.
A lot of autistic kids have real trouble with clothing. And if it's at home, what's the big deal?
Right.
Let them take the clothes off. It's no big deal.
Right.
That would be my view on that one for sure. Um,
Well, so Mary, somebody listening to this is probably saying, and it's probably a doctor or someone in training is saying, "Boy, I think I might have autism," or they're looking and saying, "One of my colleagues or my peers is obviously struggling with this and maybe was never diagnosed." What would you tell them? Like, what's the first step? Like, we don't go around diagnosing our friends, and self-diagnosis is not usually the right way to go about things. But what would you tell someone who says, I think I need more help. I need to begin the process of looking into this.
Yeah, I think just recognizing that is something that is incredibly common. Like when I started this work back in 2018, 2019, there was absolutely no sense that, doctors could be autistic. None whatsoever. We were met with complete disbelief in so many areas. But now we've got to a point 6 years later. Certainly in the UK, neurodiversity in medicine is a hot topic right across all specialties. And it's just starting in the US as well. That awareness is starting. So yeah, loads of people will be thinking that, and they'll be right mostly.
Hmm.
Um, I think the one thing I would say is I'd probably disagree with you in terms of the self-identification and the self-diagnosis, for example. For a lot of autistic people, that is very, very valid.
Hmm.
And the problem is there's such a barrier to actually accessing, a diagnostic assessment. So many people can't. I mean, even in Ireland, for example, we don't even have a diagnostic system for adults. We just don't, outside of the, private healthcare. There's no public services in Ireland at all. At least in the UK, there are public services, but the waiting list can be up to 10 years.
Hmm.
the demand, once people start to realize this, because we used to think of autism as, something that was rare. Like at one stage, it was thought to be like 1 in 10,000. Absolutely not. The most recent figures are like five, like 3, 4, 5% um, in small kids, in school kids. But we also know that, that it's going to be the same right across all demographic groups.
Right.
And so there's huge numbers of autistic adults who just haven't been picked up. And thinking back to childhood, I mean, the overriding feeling for autistic adults was of being different, that sense of oops, a daisies, sorry, let me just close that down. Um I'm not sure if that has come up on your side.
It hasn't.
Um
I can edit
okay,
that.
okay,
I
perfect.
can
Okay,
edit
you can
that.
edit it out anyway. Yeah, perfect. Okay. What was he saying? Um the over the give me a minute. The most common experience for late diagnosed autistic adults looking back on childhood is just remembering that sense of feeling different. I can remember that myself right back to preschool. So when I would have been, 3 years old and just looking at the other kids and going, these creatures are not like me. I remember that feeling, and research has shown that that's a very consistent feeling for autistic late, autistic adults diagnosed late. Um, so the question is what to do. There's a lot of screeners available online, openly available. There's one that I particularly like, which is the Ritvo RADS. And that's quite useful, I think, particularly for high achieving autistic physicians, because it looks at childhood features that we've learned to mask, as well as, current features. So I think that can be very helpful. And then the question of whether to pursue an autism diagnosis. Is something that really needs to be taken very seriously, particularly in the current political climate. Because there are downsides to having that label, particularly on medical records. Um, so for a lot of our psychiatrists in particular, they choose to not seek a formal diagnosis. As some of them say, well, like I do it at work. I know exactly what's needed. I know all the boxes that needed to be ticked, and I ticked more than the boxes that need to be ticked to be a yes. So I know. But people choose to not formalize that for various reasons. And as I said earlier, the overarching theme is shame. But there is a genuine career risk still, and potentially a growing career risk, at the moment, certainly in the US. So I would be very cautious about seeking a formal diagnosis unless, and this is not something I expected to hear myself saying. A year ago, I would not have been saying this, but unless somebody really needs reasonable accommodations at work, or there's a really good, commonly, the other thing that's a very common misconception is that being autistic in healthcare is associated with being in difficulty. And we've shown that that's absolutely not the case. The majority of our members are working away, no issues, no difficulties. But there is a minority of our membership who do run into difficulties at work. And what we find is that people tend to run into fairly, standard patterns of difficulty. And sometimes when that happens, if somebody's career, if they've got to a point where a career is at risk, then they, and being autistic can explain what has happened, then it's really beneficial to recognize that and to have a formal diagnosis. But in circumstances where people are doing okay on an individual level, I don't know would I recommend it. And yet, I also recommend when I think about I also recognize when I think about the bigger picture, particularly the fact that so much of our mental health, the really poor mental health experienced by autistic people, is related to shame and stigma. And so much of that is perpetuated by successful autistic people not, being open about their identity. There's a real conflict there. It's really difficult because there is definitely inadvertent harm being done to our community, the wider autistic community, by autistic people in sort of influential and prominent positions who know they're autistic, not feeling able to share that identity. I'm thinking particularly in terms of, politicians, for example.
Hmm.
It would be so powerful if people in those positions were able to, be confidently autistic and be openly autistic. And that's the same, particularly, I think, for our psychiatrists and our physicians in other specialties as well. but there is a genuine risk on an individual level. So the decision to disclose, the decision to seek an assessment, very much an individual level. But for those who do have the confidence to embrace this, I would say, please, we need you.
Right. So just to summarize, you can recognize it in your own self, and maybe you have to use some of the diagnostic tools that are out there, and then you'd have to decide if you're in a professional setting, whether that's helpful or not on an individual level. But like you said, Mary, if you have people who are in positions of prominence who say this is real, of course, and not only is it something that pertains to my patients, but it's something that I deal with, and you're willing to share, it's a very powerful voice. And maybe as time goes forward and this becomes increasingly recognized and we remove shame and guilt and those type of things from it, I hope that I just hope we leave medicine better than we found it, Mary. I really think
Me
that's an important thing for us to consider because right now it's ours. Right now we're the generation that are the current physicians. But fast forward
too.
20, 30 years, it's the next generation. And you want that to be better for them than it was for us. And I hope that it will be.
Yeah, we just need to normalize being autistic in healthcare, in research, in academia.
I think this will be very powerful for lots of people as they listen to it, both for themselves or and as well as trainees and family members. Many people are affected. And in fact, when you have someone who's neurodiverse or has autism in your life, rather than be ashamed or worried, you say this is a person we can celebrate because this is a person who sees the world different and we need that difference. So I think this is a great message and I appreciate you taking the time to do it.
Thanks for sharing it, spreading the word. Thanks for sharing it. Just one other final thing to say is that for anybody listening who is a doctor, who is a medical doctor, physician in any specialty, recognizes that they're autistic, come join us in Autistic Doctors International. You'll find the website fairly easily, and there's a big button on the website, message us to join. You don't need a formal diagnosis. We do accept self-identification. And there's 1,200 of us in a vibrant community where we do lots of stuff. So yeah, come check us out.
That's so great. Thanks, Mary. Thanks for tuning into the Doctors Making a Difference podcast. And thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician, and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only, and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel, and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.